the respiratory renal module. Diuretics, as the name indicates, that these are the drugs or chemical agents that increase the urine production. As you have already discussed in physiology, and maybe also in histology, that nephrons are the structural and functional units of the kidneys, and they play important role in the excretion of the waste products from the body in the form of liquid, and that liquid is called urine. So, normal urine output for adult is from 1.5 to 2 liters, or you can say 1.2 or sometimes 1 to 2 liters. If the patient is urinating more, then we say, as you are also discussing with Dr. Fatih, glucose, creatinine, these things, then it is called polyuria. If the patient is urinating less than 500 ml, then it is called polyuria. And if the patient is urinating less than 100 ml, then we say it is anuria. Okay? So these are the different types of the urine production and excretion. And you know that urine contains many things like urea, as you discussed here, creatinine. Then the important thing that apart from water, that are the electrolytes. Many electrolytes, the body, the kidneys or the nephron, they reabsorb, they go back to the bloodstream, but some of them, they also go out from the body or excrete from the body. Important one are the potassium and sodium. And with sodium, as you see, even we use it at homes, table salt, sodium chloride. So sodium goes, chloride goes, potassium goes, sometimes it is retained, but many times it goes. Magnesium is there, calcium is there, so all these electrolytes are there. How the diuretics they work? Mostly they work by inhibiting reabsorption of sodium chloride. Reabsorption of sodium chloride into the different segments of nephron. As you know from your physiology and maybe histology, that this is the basic structure of the nephron, and it starts from glomerulus. And this, what is this?
Bowman capsule.
Bowman's capsule. So Bowman's capsule, where the glomeruli, because you know glomeruli is the collection of the blood vessels. Those who come, they are called afferent. Those who are going out, they are called efferent. Okay? This is first thing. Then we have different segments of the nephron. First one is called proximal convoluted tubule, or PCT. Proximal convoluted tubule. Why it is called proximal? Because it is closer to what? To glomerulus. Very good. Second one is called loop of Henle. And we have two parts in the loop of Henle. One is called descending and the other one is called ascending. So, as you know that the urine gets concentrated when it goes up in the ascending loop of Henle. That is called thick ascending loop of Henle. Here the urine gets concentrated. So gets concentrated means that there are more solutes like sodium chloride, maybe some waste products, all of them, they are more because the urine gets concentrated. After that is distal convoluted tubule. Distal means distance, away from the glomerulus. So that is called DCT. The last one is collecting
duct.
duct. Collecting duct, and from collecting duct, then what will happen? It will go to the
Urethra.
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 Ureter. And from ureter it will go to, yes please. Yes, very good. Urinary bladder. From urinary bladder it will go to urine. Okay? So that is the story of the urine formation. You will see, go back. Earlier in the tubule they were the stronger. Earlier in the tubule they work the stronger. Who are the stronger? The diuretics. Earlier in the tubule. Earlier in the tubule means if it works in the proximal, it will be stronger. If it works in the loop of Henle, it will be stronger. If it will work in DCT, it will be weaker. Why? Because it is away from the glomerulus. Okay, so when we go away from the glomerulus, the potency of the drug is reduced. Okay? But where do we use diuretics? The question is, where do we use diuretics? Is there any criteria? Is there any parameter that we want that we should use diuretics? One of the parameter that is in the chemistry and in physiology you have already discussed is called EGFR or GFR. Murphy eraser, where I should write here, GFR. Because if you know these basic things, the rest is just story. GFR stands for glomerular
Filtration rate.
Glomerular filtration rate. So, the GFR is measured in mils and minutes. We measure it for milliliters and liters and minutes. Normal GFR value is how much? You have discussed.
125 to 200.
Yeah. Oh. 90 to 125 mil per minute. Okay? 90 to 125 mil per minute. Okay, we will try to get it from this. 180 liters of the filtrate produced daily. What do we mean by filtrate? That is because of the GFR. Now, open your calculator. 125 mil per minute. 125 mil per minute for 1 minute is 125 mil. How much will be in 24 hours?
36.
Sorry?
36.
Why 36? Just try. 125 is for okay, very good. 125 is for 1 minute. And first what we will do, we will multiply 24 into 60. And then we will multiply it into
25. 24.
24
Oh.
to 60 is done. First what we will do, because we want for 24 hours. So 60 into 24, maybe 1444, something like that. And then multiply it into 125. So what will come? 180,000. Yes. So that is milliliter. That is milliliter. So we want to convert it into
Liter.
liter. So we will divide it by
1,000.
1000. So 0, 0, 0, 0, 0, 0. How much is left? 180 liters. 180 liters of filtrate produced daily. 180 liters. But how much urine is produced daily? 180 liters?
No.
No. So how much?
From 1,000 to
No. 1.5 to 2 liter.
Liters. 1000 to 2000 milliliters.
Yes.
He is more smart. Okay. But from where this 1000 to 2000 milliliter is coming? Yes. I know you know. Because the value that we have here, that is the filtrate that the body the nephrons process every day is 180 liters. But the urine that we have in normal adult is only 1 to 2 liters or 1000 to 2000 milliliters. First thing, what about the rest of the filtrate? Where is it going?
It's reabsorbed.
It is reabsorbed. It is going back to the bloodstream. But how much is going out? 20%. Please help me. 20% of 180 liter will be how much? Do it, please.
40.
Hmm?
40.
This is, if you understand this slide, the rest is based on this slide. 20% of 180 liters.
36, 38,
38?
38, 36.
35 liters. So 35 liters, but we say 1 to 2 liters. 35 liters urine means that
36.
you are making a sea or river of water, isn't it? 35 liters every man, yeah, doctor. 178. 178 what? No, but here, here the filtrate is 180 liters. So we say that out of 180 liters, how much is going out? One idea is that 20% is going out.
1%.
1%, mashallah, very good. 1%. Was good. Only 1% is going out. So 1% will be how much?
1.8.
1.8. 1.8, that Why this is important? Because we decide the diuretics based on the urine output. And the urine output is based on GFR. The urine output is based on
GFR.
GFR. So 1% of the filtrate is going out from the body. Okay? And for this 1%, how much sodium chloride is blocked? 1% of the sodium chloride is blocked. The total sodium chloride that we have in the body, rest is reabsorbed into the nephron, only 1% is blocked. And when 1% is blocked, normal urine output comes out. That is 1.8 liters. Okay? Now, for example, we block 5%, not 3%. 5% of the sodium chloride is blocked. So what will be the answer?
9 liter.
9 liters. For example, if we block 10%,
18.
18. So go on and go down. So that is that we work on. It will depend on the inhibition of the reabsorption of sodium chloride. More sodium chloride inhibition means more urination. Less sodium chloride inhibition means less urination. But here, that what we are talking, that is for the normal GFR. Again, I need your help. For example, we have a patient where the GFR is 50 ml per minute. Please calculate for 24 hours. 50 milli per
60.
minute. We need to calculate it for 24 hours. So
Seven.
what we will do, 24 times
72,000.
60 times 50. How much it will be?
72,000.
72,000 mil. Okay? So first what we will do with 72,000, we will divide it by
1,000.
1,000. So 1,000, 0, 0, 0, 0, it will become
72.
72. Now this 72 liters, that is the filtrate. So how much urine again? Urine production will be same 1.8 liters,
No.
or it will be reduced or increased?
Reduced.
Reduced. Why it will be reduced? Because we say that only 1% of 72 will go out from the body. So how much it will be? 1% of 72 liters.
Percent?
Percent.
2.34.
Why 2.3? Yeah, doctor.
0.72.
Mashallah, very good. 0.72. You are much better than females in calculation. Mashallah. Mashallah, mashallah. 0.72 liters will be the urine production, because we calculate it for 1%. So we will divide it by 100. So 0.72 liters is the urine production. So it is okay or more or less? Less. So this is less urine production. So we will use diuretics. We will give diuretics. Diuretics are the drugs that increase the urine production. Okay? So that is for 1%. So for example, if it blocks 3%, so 0.72 times 3, how much it will be? Please help me. 6, 7, 21. Yes. How much it will be? 0.72 times 3.
2.6.
2.6.
Sorry?
Yes. 2.16. Okay. 2.16. Yeah, 2.16. So that is the urine that will be produced when the GFR is 50. So we decide the diuretics based on the GFR. But in general, like we don't have, for example, this instrument to determine the GFR. So what we do, we just ask the patient how much urine you pass normally. If he says that less than normal, so we think, oh, there is some problem with the GFR. So we start on these medicines. Okay, so that is the story of the diuretics. 1%, that is the normal. 3%, you see only 3% of the sodium chloride is blocked, 5.4 liters of the urine is produced. That is too much. That is too much. So if, for example, the drug is blocking 5%, 10%, 20%, so where we will go? It will be a big sea of water, of the urine. So normally this is how we calculate. Now we come to the diuretic agents. We classify diuretic agents based on the potency or clinical use. Like first one, that are the loop diuretics. Loop diuretics. As we discussed in the beginning, that their mechanism of action is based on the segment of the nephron. So loop of Henle, if the drug is working in the loop of Henle, then we say these are the loop diuretics. Rest names are not related with the segments, but they act in the different segments of the nephron. Mostly you will see in your clinics, because many times I told you that you don't need to recall many names. Only you need to know antibiotics, analgesics, and local anesthetics. That's it. If you are good on these three classes, you are very good dental surgeon or dental doctor. But you know that you are dealing with human beings. So a patient will be in your clinic and he might be suffering from hypertension, congestive heart failure, myocardial infarction, some other disease. And the patient will tell you, look doctor, I am using this drug for the last 20 years, for the last 10 years. So at least you should have an idea that what is going on with this gentleman. So one of the drugs that is very commonly used, and you will notice it in your clinics, that are the diuretics. Why? Because even today, one of the largest killer of the human beings after America, that is the hypertension. Blood pressure is one of the largest killer. Even today, although there is so much research, there's so many drugs. Diabetes and cardiovascular, these are the two areas where the maximum research is going on, because money. But still, they are, both of them, they are the largest killer. Diabetes as well as hypertension. And you will see 90% of the patient, they will be having hypertension as well as diabetes. So they go side by side. Cardiovascular, one of the cardiovascular diseases is hypertension. Okay, the next group is thiazide and thiazide-like diuretics. Then we have potassium-sparing diuretics, triamterene and spironolactone. Then we have osmotic diuretics, IV mannitol. And then we have carbonic anhydrase inhibitors, no more used as diuretics, used as in IOP. Okay, IOP stands for intraocular pressure. We discussed somewhere in parasympathetic, maybe, intraocular pressure. The pressure inside the eye, very good. So if the pressure inside the eye is increased, what happens? Glaucoma. This is a disease that is called glaucoma. Glaucoma. Glaucoma is increased intraocular pressure due to accumulation of fluid in the eye. Okay? So nowadays we use carbonic anhydrase inhibitor, only in the treatment of IOP. No diuretic use. So if you get question on your exam, which of the following diuretic is no more used as diuretic? CAI. IOP is the use today, but we don't use it as diuretic. No more used as diuretic. Okay, go to the next one. That is osmotic diuretic, or here we say IV mannitol. IV stands for
Intravenous.
intravenous, because mannitol can be used orally also, but orally it is used for different thing. When we use it IV, it is used as diuretic. This is the most potent diuretic. This is the most potent diuretic, but the problem that it is used only IV. So IV means that it is used in hospitals or emergency. Why it is the most potent? If you remember in the beginning I told, the closer we are to the Bowman's capsule or to the glomerulus, the potent will be the diuretic. So because it acts, you see this one is mannitol, it acts in the first segment, that is the proximal convoluted tubule. So it is the most potent diuretic. But the problem is that we use it IV. So IV, and you see these patients need it for lifetime. So every day you cannot take drug IV. So that is the problem with. Otherwise, it is the most potent. You will see, God forbid, road accidents where there is intracranial pressure is increased. Other problems where there is emergency, so they give mannitol. But in general, we don't use in practice. Okay? Now we go to the others, because we will discuss all the three groups. First one, that are the loop diuretics. There are many names in these loop diuretics. I hope, inshallah, you will not use any one of them, because you are not directly related. But the one that you will see in your clinics quite commonly, that is the furosemide or furosemide. The first one, underline it. Furosemide or furosemide. Yeah, furosemide, you will see many patients they are using for many years. That is one of the commonly used loop diuretic. The second one is bumetanide, then torsemide, and the last one is ethacranic acid. They are same. Their mechanism of action is same. They will act on the loop of Henle and inhibit the reabsorption of the sink water, sodium and chloride. Ethacranic acid is different chemically. Structure of the ethacranic acid is different. How it is different? That you see, first one is furosemide, second one is bumetanide, third one is torsemide. All of them, they have sulfur group. You discussed even in microbiology sulfonamides. So sulfur group, they contain sulfur group. So what is the problem with sulfur group? That some individuals, they are allergic to sulfur group. That glucose 6-phosphate dehydrogenase deficiency, you might have discussed even with Dr. Fatih. We discussed also in general pharmacology. So if someone is allergic to sulfur group and still he needs the loop diuretic, so what we will use? Ethacranic acid. So, if you get question on your exam, you have a patient who needs a loop diuretic but is allergic to furosemide or butenide or torsemide. So, which of the following is the appropriate
Ethicrenic acid.
ethicrenic acid? So, it will be ethicrenic acid. Okay. Mechanism of action we discussed. Used primarily for edema in heart failure. Used primarily for edema in heart failure. All of them, whether it is furosemide, whether it is butenide, whether it is torsemide or ethicrenic. Primarily, the first use of these drugs that they are used in edema. And you know edema means accumulation of
Fluid.
fluid. And fluid means accumulation of water and water and what? Only water? Sodium is important because it has the retention capacity. It has the retention capacity. So keep in mind, this is very important, it will help you in your life. Sodium goes, water goes. Sodium retains, water retains. Sodium goes, water goes. Sodium retains, water retains. So, furosemide is the first line. First we will try furosemide. But for some reason, if we cannot use furosemide, then we can use torsemide. Next step after furosemide is torsemide. There is no difference between furosemide and torsemide. One difference may be the duration of action. Torsemide is long acting. Torsemide is long acting. The patient may need once a day instead of twice a day preparation of furosemide. One thing. Second important thing that you will notice in your clinic, that the patient will tell you, doctor, I use this drug in the morning. This drug means any diuretic. Any diuretic ideally should be taken in the morning. Why? Because if you prescribe diuretic at night, 7 p.m., 8 p.m., 9 p.m., what will happen? The patient will not be able to sleep at night. Why? Because he will go to washroom. So, ideally, diuretic should be given during daytime. Okay? Because the patient is awake, so he can go to washroom. So that is important for us. As we discussed, if there is sulfur allergy, then we will use ethicrenic acid. Butenide has one more use. They also use, but butenide is specifically used. Ascites are more than cirrhosis. Who will tell me what is ascites? Both of them are related with liver failure. Dr. Ali likes it like anything because ultimately goes to cancer. Yes, hepatocellular carcinoma
Normal buildup
of
fluid in the
abdomen, water retention or fluid retention, sodium retention, albumin retention in the abdomen, in the peritoneum. So for that we use butenide. Butenide is used in that situation. Again, the first line for the edema in the heart failure is furosemide. We always start our treatment with furosemide or furosemide. The mechanism of action of all is same. They will block sodium chloride sympathers in the ascending thick loop of Henle, tall. Okay? Side effects. First side effect, if you see, it is written in capital letters, bold and underlined. hypokalemia means
Deficiency of
potassium, low concentration of potassium. Low concentration of potassium is important, or concentration of potassium in the plasma or serum is important. Why? Because potassium plays important role in why if potassium goes up problem, goes down problem. Normal value of potassium, serum potassium is value. You discussed with Dr. Fatih. Huh? 4. Okay, accepted. 0.4. Yeah. 3.5 to 5.3. 3.5 to 5.5. 3.5 to 5.3. Just for convenience. But even 5.5 is accepted. Less than 3.5 or less than 3 will be considered hypokalemia. More than 6 will be considered hyperkalemia. Both are problematic. Why? Because potassium plays important role in action potential. And action potential is very important for the heart. So if there is a decrease, problem. If there is increase, problem. So that is the important thing. Hyper and hypo. So hypokalemia is important. It can also cause hypocalcemia, it can also cause hypomagnesemia, and it can also cause autotoxicity. Toxicity in the ears, even deafness. The patient may suffer from loss of hearing when we use it in larger doses. You see, the mechanism of action says that it should block sodium chloride and sodium should go out from the body. But we didn't mention sodium in the side effects. If sodium is going excessively from the body, what will be the condition? Hyponatremia. But because the margin is high, it is from 130 to 140, so clinically it is not important as compared to potassium. You see potassium is there. Every diuretic, hypokalemia is important. You will not see hyponatremia except maybe osmotic diuretic that cause excessive loss of the sodium. Otherwise we don't mention that. Hypokalemia, that is important. So if you get question on your exam, write the most important side effect of the loop diuretic. Then you should write hypokalemia. Okay, if you write any other, that will not be the correct answer. The correct answer will be hypokalemia. Why? Because clinically it makes problem. Reduce, it can lead to renal failure. Increase, it can lead to arrhythmias. So you will take this. Next is thiazide diuretics. There are many names, but we will take only 3 that are important for us. First one is hydrochlorothiazide. Mostly you will see patients using hydrochlorothiazide. Then we have chlorothiazide. Then we have metolazone. Then we have indapamide. And then we have chlorotoluene. Hydrochlorothiazide, underline it. Chlorothiazide and metolazone, cross it. Second and third cross. Hydrochlorothiazide. This is thiazide diuretic that we use in practice. Indapamide and chlorotoluene are thiazide-like diuretics. They are not thiazides, but they are thiazide-like diuretics. Why? Because they act on the same site. They act on the same site in PCT, DCT, the distal convoluted tubule. They act in DCT Chemically they are different, but mechanistically the mechanism of action is same. So hydrochlorothiazide, indapamide, and chlorthalidone. You will see mostly in your clinics nowadays indapamide. Why? Because it is potent. Smaller dose, 1.25 milligram is equal to 50 milligram of hydrochlorothiazide. So you will see, but it is expensive as compared to hydrochlorothiazide. What is the mechanism of action? Same, but only the segment is different. In case of loop diuretics, it acts in the loop of Henle. Here it will act in the DCT, distal convoluted tubule. Okay. Now when it acts in the distal convoluted tubule, the diuretic effect is less. The diuretic effect is less. So we say it is moderate or mild to moderate diuretic. It doesn't cause excessive urination. Why? Because the mechanism of action of the diuretic is based on the distance to the glomerulus. Away from the glomerulus, less effective. Closer to the glomerulus, more effective or more potent. Okay. Where do we use them? Used primarily for hypertension and adjunct in HF. HTN is hypertension and HF is
Heart failure.
heart failure. So, inshallah, next module is cardiovascular. You will see when we start any patient for the treatment of hypertension. There is a protocol, you know protocol. So, there is a protocol. First, we will determine after 3 readings at 3 various settings that the patient is suffering from hypertension. Single sitting readings, you cannot determine that the patient is suffering from hypertension. We will ask the patient, okay, check today, maybe tomorrow, after 2-3 days again, or come back if it is possible. But nowadays you see these devices available everywhere, digital devices, even at home you can check. Once you decide that this is hypertension, like the blood pressure is 140 over 90, 140 over 100 mmHg. So what we will do first? First we will make lifestyle modification. We will ask the patient, start walk, exercise, reduce sugar, say goodbye to sodium, maafi sodium chloride. Very difficult. Food without milk, it is very difficult. You cannot imagine. It is more difficult than sugar. You can take tea without sugar like you like. Yes. But without milk, it is very difficult. But still, that is lifestyle modification. Chai? Milk, salt. No, in food. Yeah. If you have albake without salt, maafi, huh? No taste. So it gives taste. 2 things gives taste to the food. Food that we take meal. First one is salt and second one fats. You add more fats, more tasty. Without fats, less tasty. Like you know the difference when you boil chicken and when you fry the chicken. So this is the difference. Come back here. So lifestyle modification is failed. You ask the patient, do it for 3 months, still the blood pressure is high. So what is next step? We will start with thiazide diuretic. We will start with thiazide diuretic. So that is the, if thiazide diuretic is failed, then we will go to next. There are many tricks. Inshallah, we will discuss them. One of them is that. Okay. But what is important? The side effects. Increased cholesterol, increased glucose, increased uric acid, and increased calcium. Now I need your help from your medical terminology. if the cholesterol level is increased in the blood. What will be the terminology that we use? Hypercholesteremia. Very good. Hypercholesteremia. By the way, what is the normal cholesterol level? Mafi? Okay, you will discuss that. It is more than 200 milligram per cent. Okay, next is glucose that you discussed with Dr. Fatih just maybe yesterday. If the blood glucose level is high, what is it called? Hyperglycemia. What is the cutoff value? More than what?
Normal level, the normal range,
No?
80 to 100.
Okay.
120 milligram per deciliter.
Okay. 126 milligram percent means hyperglycemia. 126 milligram per deciliter means hyperglycemia. 126 is the cutoff value. 126 milligram per deciliter. Before this is pre-diabetes, but 126 and above means diabetes or hyperglycemia. Good. This is one of the drugs that can cause diabetes. Why? Because it causes hyperglycemia. Okay. Next, uric acid level is increased. So what will it be called? Hyperuricemia. Very good. Hyperuricemia. What do we mean by hyperuricemia? What will happen to the patient? Gout, knuckles,
Just accumulation of acid in the
uric acid in the joints.
Yes.
So that is called hyperuricemia. And the last one, it will cause hypercalcemia. So these are hyper. Hypercholesteremia, hyperglycemia, hyperuricemia, and hypercalcemia. What about hypo? It will cause hypokalemia, hyponatremia, hypomagnesemia. Okay? So both are important. Hyper and hyper. Why it is important? Because thiazide is used for longer duration. What I told you, will see patients, they will be telling you, I am using for the last 20 years. The first thing that should come to your mind, the patient is suffering from some cardiovascular problem. Because for routine practice, we don't use it for so longer duration. But when we use it for so longer duration, what can happen? These side effects can happen. Hyper and hyper. Clear? Go to the last, but not the least. Diuretics, adjunct agents. What do we mean by adjunct agents? That alone, they are not sufficient as diuretics. They need a friend.
Combination.
They will be always given in combination. You will never see them alone to be used in the management of diuresis. So they are called adjunct. If you remember, we discussed just shortly that our concern when we use diuretics is hypokalemia. Our concern is hypokalemia. These drugs, they spare potassium. They say to potassium, go back to the bloodstream. They don't disturb potassium. They take away sodium, but they don't disturb potassium. They act by two different mechanisms. Both of them, they are potassium sparing groups, but they act by different mechanisms. First one, potassium sparing diuretics, they are mineralocorticoid receptor antagonists. Mineralocorticoid, they are the steroids. Mineralocorticoids are the steroids. Inshallah, we will discuss in next term. What they will do, that they will block mineralocorticoid receptors. The mineralocorticoid that we have in our body, we produce, that is aldosterone. That is aldosterone. Why aldosterone is important? Mineralocorticoid. Mineralo means minerals like sodium, potassium. They regulate the minerals in our body. Aldosterone. Aldosterone, as you discussed maybe with Dr. Ali, renin, angiotensin, aldosterone system. It is one of the important component of the regulation of blood pressure in our body. Why? Because aldosterone regulates minerals, especially sodium. Sodium is important. Okay? When sodium is retained in the body, who will be retained?
Potassium.
Water. Sodium retains, water retains. Sodium goes, water goes. So, in general, like we don't use any drug, the body is producing aldosterone. It maintains or it retains sodium and also it retains water in the body. But because this is a normal procedure, it is a cycle that goes on. In diabetic patients, in hypertensive patients, this is increased. The accumulation of fluid is increased. Okay, now the mechanism of action, it will inhibit aldosterone. We use it in CHF1 and 2 hyperaldosteronism. CHF stands for
Chronic
chronic
heart failure.
heart failure or congestive heart failure. Congestion means zahma, accumulation of water. What I told, that there is a condition where there will be more accumulation of water, and the reason will be aldosterone. So we will say congestive heart failure stage 1 and 2 hyperaldosteronism, where the aldosterone level is high. So in that case we will use spironolactone and amplirenone. Mostly we use spironolactone, but we also use amplirenone. The side effects are important. What it will do? It will cause hyperkalemia. Why? Because it spares potassium. Yeah, it takes away sodium, but it doesn't say anything to potassium. So that can lead to hyperkalemia. And hyperkalemia means arrhythmias. It means arrhythmias. But again, why it is not significant? Because we always use it in combination. We always use it with furosemide. We always use it with thiazide. So there is balance. They are taking away potassium and it is replenishes. It increases the potassium. The other one is gynecomastia. S greater than E. S stands for spironolactone, causes more than amplirenone. Gynecomastia. What is gynecomastia? Enlargement of breast in males. Okay, so that is one of the important. The other one that acts on the epithelial sodium channels, DCT and collecting duct, the last two portions of the segment. So they are weak diuretics. Again, we give it in combination.
Also this.
The second. But the thing that is important, that it doesn't have effect on aldosterone. It has no effect on the mineralocorticoid receptors like spironolactone and amplirenone. So keep in mind that their mechanism of action is different from the spironolactone and amplirenone in the sense that it doesn't block aldosterone. It spares potassium. It doesn't take away potassium from the body by different mechanism. Okay, so where do we use it? We use it for HTN. What is HTN? Hypertension. Again, you can write in bracket adjunct. We will use it in combination with other antihypertensive drugs, with other diuretics. Alone, it is not used because it is not sufficient to cause that much antihypertensive effect. Side effects, hyperkalemia. Why? Because it also spares potassium. It doesn't say anything to potassium. But it does not cause gynecomastia. Why? Because gynecomastia is related with aldosterone and it has nothing to do with aldosterone. This is the story of diuretics. Thank you, and inshallah, prepare your